All right, today we're going to be talking about endotracheal intubation. My name's Adam. I'm a paramedic, so I have a little bit of experience doing this. So first and foremost, when you're talking about intubation, you're going to be doing this for cardiac arrest, respiratory arrest, and then a pending respiratory failure. So this may be your last ditch effort to do anything before that patient goes into respiratory arrest. When they're in respiratory failure. So when you have your patient, the first thing you want to do is assess, make any correctional movements to the airway that you want. So you don't want your patient sitting down chin to chest. So you want to get that airway nice and open in the sniffing position, not hyperangulated, just in a good neutral sniffing position. Once the patient's good and positioned, we want to make sure the airway is clear, so it's always a good habit to suction. Make sure the airway is nice and suction clear. After that, you do want to pre-oxygenate your patient with a bag valve mask. Remember your technique like you learned in CPR, the CE method. Get a hold to the bottom of the jaw and just nice and ventilate. So it's best to have two people doing this. So you have a partner here pre-oxygenating the patient while you have all your equipment out and you're getting that ready. So the equipment you're going to need is a laryngoscope, the blade, your ET tubes. I always like to have the size that I think I'm going to want. I always size my tubes. Normally if you look at the patient's pinky finger, that's a pretty good range of.
So these are all different sizes?
Yep, yeah, so that's an 8, 7.5, and 7. I'm a bigger guy, so that 8 is pretty close to the same size as my pinky. So if we're intubating me, we would want to go with
and
the 8.
You use the pinky finger rule that's on your patient.
Yeah, so whatever size the patient's pinky finger is a good tool to kind of use to figure out what size you're going to use. Generally, the average adult, we can intubate each other all day long with anywhere from a 7 to an 8. It doesn't matter if it's a smaller female or a big male. You can generally use anywhere from 7 to 8. That's going to be your average size. I would say average size ultimately is anywhere 7, 7.5. But we do have some bigger guys out in the population that pretty saturated with that, so 8 would be fine. So I would say that's your common sizes there, 7, 7.5, and 8. So we have our ET tubes here, and then you have your assistant devices. So whether it's a pliable stylet, a bougie, and we also have rigid stylets as well. So you want to always have some sort of assistant device out and ready. Which one you choose is kind of personal choice. It's just after you get to doing it and you get your routine, you'd find what works best for you. And different scenarios call for different devices. So we have that. You always want to make sure you have your syringe, which I know I have one. There it is. So have your syringe out and ready. Secure device, N-title. We already have our BVM, our partner's pre-oxygenating still, and you can also use a video laryngoscope device as well. And then it's always a good rule of thumb to have some sort of backup device, whether it be a king tube or an iGel, just in case your intubation attempt is a fail. So it's also good, once you have everything laid out you need, to take the tube in which you're going to use and pre-fill the bulb to make sure the bulb works. On these, there's normally, it tells you how much, but generally 10 cc's of air for an ET tube, 10 to 12. So, looks good, no leaks. So that tube is good, ready to go. I personally like using a stylet. So I preload the stylet. I found that making it look like a hockey stick at the end works for me. So that's good, that's ready to go. Securing device ready. End title, all that's ready. So when you come in to intubate, like I said, we pre-oxygenate because when we go to do this intubation attempt, it's a period of apnea the patient's in. So no one's breathing for the patient, the patient's not getting oxygen. So the quickest we can do this, the better off we are, as long as we're successful. Generally, a good rule of thumb is you want to be 30 seconds and less on your intubation attempt. And if not, if you get in, you realize you're going way too long, just back out, pre-oxygenate, and you can give it a second attempt. Really don't want to go over 3 attempts.
What's the advantage of using an ET tube over like your King or your iGel?
So this is going to be a definitive airway. So once this goes in, you're going through the vocal cords into the trachea, and this seals that off. So you don't have to worry about gastric distension, any vomitus coming up, getting into the lungs. You know, aspiration and all that stuff is out the window. Every bit of the air that you put through this tube is inflating those lungs. So that would be your main benefit. These are technically designed to where this cuts off.
Cuts off the esophagus.
Esophagus, there you go. This cuts off the esophagus and this blows air straight down the trachea. So this is technically designed to do a similar job, but it's not always.
That's just better quality.
This is much better quality. This is, you know, this is working. So we got everything set up. We've pre-oxygenated. So when you go to enter, you also want to check your laryngoscope, the blade, make sure the light works. So when you go to enter the airway, you want to come in from the right, scoop the tongue to the left, and hold the tongue to the left. You're riding the tongue down until you get to the vallecular, which is the space where the tongue and the epiglottis meet. The epiglottis is the flap that covers your trachea when you swallow and when you eat. It ensures nothing gets down your trachea. So once you hit that space and you push in a little bit, you should see that epiglottis push forward. That's when you know you're in the right place. And when you're intubating, you want to go up and out, not back. When you go backwards, that could definitely cause some dental trauma, and also restricts your view of the airway as well. So have your ET tube ready, sweep the tongue to the left, we're at the vallecular, we go up and out.
I should have Lucas Mannequin on, but.
Alright, so once we've intubated, you want to pass the cords through the vocal cords and pass the tube through the vocal cords and advance it about 1 centimeter after that. Once the tube is in and advanced, you always want to keep a hand on the tube to ensure it doesn't go anywhere. We always look, confirm what our number is at the teeth. So we're sitting at about 20 at the teeth right now. Remove your stylet. When you're talking about stylets, you remove the stylet in which the same way you put it. So we went in and forward. We're coming up and backwards like that. You do that to reduce any chances of any airway trauma. So you have someone at this point, keep your hand on, get a partner to ventilate the patient for you. And then we confirm the tube. So we'll confirm the tube with end-tidal CO2. So we put on our end-tidal reader. So we should start getting end-tidal reading now, but you can also use your stethoscope to auscultate lung sounds, and also you want to check for absent gastric sounds as well. So once the tube is in, confirmed, that's when you want to secure it. So we got the securing device. You still want a second person helping you at this point, someone holding the tube and someone putting this device on. once the tube's in, secured, even though we already confirmed it before, we got all those movement, and sometimes these devices will cram the tube to the side of the mouth. So we also then want to circle back around and reassess to make sure we still have in-tidal reading on the monitor, epigastric sounds are absent, and lung sounds bilateral. So if you intubate and you'll have unilateral breath sounds, normally you would have right-sided unilateral breath sounds. That's when you would want to deflate the cuff. I forgot to inflate the cuff. So when you intubate, first step, inflate the cuff, then you confirm. Deflate the cuff, and then you'd want to back the tube out approximately 1 to 2 centimeters. Reassess. I always say when you're backing out the tube, it is a good rule of thumb to have your laryngoscope blade eyeing that. You do not want to pull the tube all the way out. So once you're successful, reassess, and then anytime we move this patient, whether it be on a backboard, on the Lucas device, or to the ambulance, this tube needs to be reassessed after every movement.
Does the depth matter? I know you said, because it looks, to me, it looks like it's sticking out far, but.
Yeah, so the depth does matter, but as long as you have the tube in, you've confirmed the tube and it looks good. As far how far out it's sticking, it doesn't. It does matter, but it also doesn't. As long as you have a good tube and it's confirmed. It really matters if you're really far in and you have those unilateral breath sounds. That's when you have right main stem dead. So all the air is only going to the right lung instead of both the left and the right lung.
That just comes down to body composition where everybody's different, so that's where you get like the different variation.
Yeah, yeah. So if you want to step around here, you can kind of, this shows there's a video laryngoscope, so we can talk about anatomy a little bit better. So that space right there is the ventricular. That's where we're aiming to put the tip of our scope at, right there. And then that flap is your epiglottis.
So as you went, you said you started on the right and worked left, right?
Yeah, so you go into the right, you're scooping the tongue and moving it over to the left, that way it's out of your way. Mannequins are a little bit different than humans. Humans' tongue's gonna be a lot more floppy, so thus getting this technique down on the mannequin, it really helps you in a live intubation. So there's your molecular, epiglottis is there. Lift up and away, the cords are there, they're exposed. Should have had this. So we'll talk about the rigid style left. These are very important. You come out the same way you go in, or you will definitely cause trauma to the trachea, vocal cords, airway. So we're watching the tube, it passes. You advance just a little bit. Bring this out, hold the tube, and it comes out the same way it went in.
You gotta make sure you get that curve and everything.
Yeah, you gotta come back out the same way it went in. And now we inflate the cuff. It's nice and inflated. We're holding. BVM. We have lung inflation. Now let's confirm with in-tidal. In-tidal looks good. We're checking lung sounds bilaterally. Look good. Absent gastric sounds. So then we secure. Secure, and now we reassess. Lung sounds look good. In-tidal, all is good. Does that make sense? Any questions?
What happens if you mess up? You said that's where you can go back and try
So
to hide.
yeah, if you're on like attempt 3 and all else fails, it's looking like, you know, it's either a super anterior airway or
Could it just be you picked the wrong tube size too, or that doesn't matter? I mean,
So
I know
it
you
could-
said it does and doesn't, but.
It could be. If you've done 2 attempts and you're going in for your 3rd attempt, it might not be a bad idea to see if you can drop tube size and get it in. It really depends on, are you just having trouble seeing the vocal cords, or are you having trouble actually passing the tube through the vocal cords? If I'm having trouble passing my tube through the vocal cords, I'm going to decrease my tube size. But if I'm having trouble seeing the vocal cords, that's when I'm going to change. I'm going to change something else. So I'm going to go from a regular Mac style blade to a hyperangulated blade that will definitely get in there and hook into that vallecular area and your epiglottis a little bit deeper, for a more anterior airway. And I would honestly, instead of using this pliable stylet, I would probably change to more of a rigid stylet to where I can actually get that tube up into the anterior airway. And a lot of times the anterior airways, from my personal experience, it's easier to do those with the video laryngoscope versus your traditional direct.
They have to show up on every ambulance. Do you have every one of these, or is it just this kid or just that kid?
No, we have all of it. We have all of it. And then if all else fails, you go to your backup, which is an iGel, and you just cram it in there. Make sure we have compliance, and we do. If you did not have compliance, you would back it out just a little bit until you did, and that's when you'd stop, and you'd secure that in place. Make sense?
Yeah.
All good? Sweet. That's the end of my presentation.